Kanski lecture series, and this is going to be the lacrimal drainage system part 3. And in this part we are going to discuss about the congenital obstruction, and then we will discuss about the acquired obstructions. So one of the most common things that you will encounter is the nasolacrimal duct obstruction. The lower end of the nasolacrimal duct in the region of the valve of Hassner is the last portion of the lacrimal drainage system to canalize with complete patency, most commonly occurring soon after birth. Epiphora affect at least 20% of the neonate, but spontaneous resolution occur in approximately 85% within a first year. So basically, you know that there is a lacrimal drainage system. This is the canaliculi that join to form the common canaliculi. Then there is a lacrimal sac, and then there is a nasolacrimal duct, and beneath at the lower part is a valve of Hassner. So whenever there is an it is basically obstructed or fail to canalize, mean that it is not completely patent. It will cause the obstruction of the nasolacrimal duct, and besides that, the tear formation in the babies are not so much. Still the tears stagnate, and it causes the epiphora, and accumulation of the material causes the nasolacrimal discharge. So epiphora and matting of the eyelashes may be constant or intermittent, and may be particularly noticeable when the child has an upper respiratory tract infection. Superimposed bacterial conjunctivitis may be treated with a broad spectrum topical antibiotic. So basically the patient, the neonate or a child may comes to you with a complaint of epiphora, means the watery discharge from the eyes. But whenever there is a significant stagnation and there is a bacterial infection, it will cause the mucopurulent discharge. So in that case you will have to give the topical antibiotics. Gentle pressure over the lacrimal sac may cause mucopurulent reflux. Acute dacryocystitis is rare. Normal visual function should be confirmed as far as possible, and an interior segment examination with assessment of the red reflex performed. The fluorescent disappearance test set see above is highly specific in this setting. Only a fine line of dye at most should remain 5 to 10 minutes under inspection with a blue light in a darkened room. So basically you have to check the visual acuity, and you can do the, because the syringing and other tests are very time taking and needs anesthesia in a child. So basically you need to perform a fluorescent disappearance test, that you put the 1 to 2% of the fluorescent and it will disappear after 5 to 10 minutes. So differential diagnoses include other congenital causes of a watering eye, such as punctal atresia, congenital glaucoma, chronic conjunctivitis, keratitis, and uveitis as well. So you can see figure 3.17, a child with the watering eyes. 3.18 is showing the probing of the nasolacrimal duct. So how will you treat massage of the lacrimal sac has been suggested as a mean of rupturing a membranous obstruction by hydrostatic pressure. The index finger is placed over the common canal. So treatment is the massage of the lacrimal sac has been suggested as a mean of rupturing a membranous obstruction by a hydrostatic pressure. The index finger is initially placed over the common canaliculus to block the reflux, and then rolled over the sac, massaging downward. The likelihood of the success and the optimal regime is determined. So basically in case of massage, what you do is basically you are pressing it in a downward direction, so by the hydrostatic force it will open the obstruction at the nasolacrimal duct. So first you will put your finger here, then you will massage the lacrimal sac and push it in the downward direction. So that is how you do the nasolacrimal massage. So if this fail and the symptoms are still not resolved, and then you can proceed to a probing. It is basically the passage of a fine wire by the canalicular system and the nasolacrimal duct to disrupt the obstructive membrane at the valve of Hassner is usually regarded as a definitive treatment and may be preceded and followed by irrigation to confirm the site of obstruction and subsequent patency respectively. Probing can be replaced if the first procedure is repeated. If the first procedure is unsuccessful, nasal endoscopic guidance may enhance success and should be considered at least for the repeat procedure. If symptoms are mild to moderate, probing may be delayed until the age of 12 to 18 or even 24 months and is carried out under general anesthesia. For more marked symptoms, early probing may be appropriate, and in younger children, sometimes performed under topical anesthesia in an outpatient setting. Risks include the induction of the canalicular stenosis due to probe trauma, which may be relatively common. It should be noted that there is a little evidence of a difference in a final outcome at 24 months conferred by the intervention versus non-intervention. Failure of probing may result from the abnormal anatomy, which can usually be recognized by difficulty in passing the probe and subsequent non-patency of the drainage system on irrigation. So basically, after 1 year, or you can say 12 to 18 months, when there is still no the symptoms are still there is still epiphora and the symptoms are not resolved, then you can proceed to a procedure called probing. Probing is basically you pass the fine wire through the canalicular system into the nasolacrimal duct and you relieve the obstruction by that. So in a case it is sometimes it is resolved, but sometimes you have to do the repeated probing, and in the repeated probing there is a good way if you also use the nasal endoscopic guidance, so to see the probe into the nasolacrimal duct. And also one more thing is that you also irrigate the sac to see that if there is any fluid that passed through the nose. So that is how you will perform the probing, and you, as he is a kid, so you will perform it under the general anesthesia. Option after probing failure include intubation with celestic tubing with and without balloon dilatation of the nasolacrimal duct, endoscopic procedure, and dextrocystorhinostomy. So basically these are other procedures that you can perform if the probing is still failed, like you can perform celastic tubing, you can perform balloon dilatation, even you can perform the dextrocystorhinostomy. Another thing is a congenital dacryoceal. A congenital dacryoceal or amniotoceal is a collection of the amniotic fluid or mucus in the lacrimal sac caused by the imperforate Hassner valve. Presentation is perinatal with a bluish cystic swelling or at or below the medial canthus accompanied by the epiphora. If an intranasal component is large, it can cause respiratory distress, which should not be mistaken for an encephalocele, the latter being characterized by the pulsatile swelling above the medial canthal tendon. Resolution is common with only conservative treatment, but if this fails, probing is usually adequate. A congenital dacryoceal should not be confused with the encephalocele, which is characterized by the pulsatile swelling above the medial canthal ligament. So basically, in a case of a congenital dacryoceal, there is an accumulation of a amniotic fluid into the lacrimal sac, so it will give the bluish cystic swelling on the medial side of the eye. So you can see that this is a congenital dacryoceal, and it is one of the things that you can understand the differences between the congenital dacryoceal and encephalocele. Basically, the dacryoceal is below the medial canthal tendon and ligament, and encephalocele is above that, and it is also the pulsatile lesion, whereas the dacryoceal is a non-pulsatile. You basically treat it with the conservative management, but sometimes probing is also necessary. Next is the chronic canaliculitis. Chronic canaliculitis is an uncommon condition frequently caused by the Actinomyces israeli anaerobic gram-positive bacteria. Occasionally, scarring and canalicular obstruction may result. Presentation is with unilateral epiphora associated with chronic mucopurulent conjunctivitis refractory to conventional treatment. So basically, the very common organism or MCQ's point of view is what is the cause of the chronic canaliculitis that is very common is it is actinomyces israeli. It is a gram positive bacteria, and one will present with the unilateral epiphora, and there will be the mucoplurin conjunctivitis that will not be usually not respond to the normal treatment. There is a pericanalicular redness and edema and mucoplurin discharge on pressure over the canaliculus. A pounding puncta may be diagnostic clue in male cases. In contrast to the decrucystitis, there is no lacrimal sac improvement. In contrast to the decrucystitis, there is no lacrimal products of actin. There is no lacrimal sac involvement. Concretion sulfur granules are metabolic products of actinomyces and other hydrogen sulfide utilizing bacteria. Classically are expressed on canalicular compression or following canaliculotomy. A topical antibiotic such as fluoroquinolone 4 times daily for 10 days may be tried initially but is rarely curative unless combined with the canaliculotomy. A linear incision into the conjunctival side of the canaliculus and curettage of the concretion. Giant fornix syndrome, dacrylithiasis, and lacrimal diverticulum may give a similar clinical picture. Herpes simplex is a classic cause of the acute as opposed to the chronic canaliculitis. So, basically, actinomyces israeli will produce the yellow granules, and that will obstruct the canaliculi. So, if it obstruct the canaliculi, the main how will you treat it? You basically press the lesion and express the granules, and then give topical antibiotics such as fluoroquinolone. But most of the time canaliculotomy is required. Canaliculotomy is basically you cut the canaliculi and you express all the granules, sulfide granule, and then you give the topical antibiotics as well. And one of the important thing is that acute canaliculitis is caused by the herpes virus. So tip is chronic canaliculitis should be suspected in a patient with a unilateral mucoplurin conjunctivitis that is refractory to conventional treatment. So this is a chronic canaliculitis. A is showing gram stain of actinomyces israeli. B is showing mucoplurin discharge and pressure over the inflamed upper canaliculus. And C is showing the sulfur concretion released by canaliculotomy. Next is the decrucystitis. Decrucystitis is basically the inflammation of a lacrimal gland. It can be acute and a lacrimal sac. It can be acute and it can be chronic. Infection of the lacrimal sac is usually secondary to the obstruction of the nasolacrimal duct. So whenever there is a nasolacrimal duct blockage, it will cause the stagnation of the tears and the bacterial growth in that. So it will cause the acute decrucystitis. It may be acute or chronic and is most commonly staphylococcal or streptococcal. Acute decrucystitis. Presentation is with the subacute onset of pain in the medial canthal area associated with epiphora. A very tender, tense red swelling develop at the medial canthus commonly progresses to the abscess formation. There may be associated preseptal cellitis. So basically, what you will see in the acute decrucystitis, you will have a pain in the medial canthal region, and there will be the very tender swelling at the medial canthus, and that will lead to the abscess formation. And sometimes there will be the associated preseptal cellitis. Treatment. Initial treatment involves the application of a warm compresses and oral antibiotics such as flucloxacillin and co-amoxiclav. Irrigation and probing should not be performed. Incision and drainage may be considered if pus point and an abscess is about to drain spontaneously. However, this carries the risk of a persistent sac skin fistula. Decrucystal rhinostomy is commonly required after the acute infection has been controlled and may reduce the risk of recurrent infection and may result in the closure of the fistula. So basically, you can do things like, first of all, you treat it with the oral antibiotics. And if there is an abscess formation, you can do incision and drainage, but that can has a complication of leading to the fistula formation. And decrucystal rhinostomy you can perform when the acute infection settled down. Then there is a chronic decryocystitis. Presentation is with chronic epithora, which may be associated with the chronic or recurrent unilateral conjunctivitis. A mucocele is usually evident as a painless swelling at the inner canthus, but it is an obvious swelling is absent. Pressure over the sac commonly still result in a mucopleural canalicular reflux. Treatment is with dextrosystorhinostomy. To reduce the risk of endophthalmitis, postpone intraocular surgery if there are any signs of the lacrimal drainage system infection. So basically, the chronic decryocystitis does not have acute signs of a disease, like it will not have any pain, it will not have any redness, but there will be the swelling in the medial canthal area, and that will, if you press it, that will result in a mucopleural reflux formation, and the treatment is with the um, DCR. So figure 3.21 is showing acute decryocystitis, B is showing lacrimal abscess and preseptal cellulitis, C is showing lacrimal fistula with fluorescein, D is showing healed lacrimal fistula. So A is showing mucocele and B is showing expression of the mucocele material by applying pressure to the sac. So that's it for the lacrimal drainage system part 3. See you in the next lecture series.